Good Saturday morning to everybody, and welcome to HyperFit Radio Show with Dr. Charles and Francesca Guglin from HyperFit MD in Milford. They are an age management center. Hey, good morning, guys.
Morning.
How are you?
We're good.
It's good to see you again.
We're healthy and vibrant.
Well, that's key, especially in February.
Yeah.
How's your week been? How was your week, I should say?
Good. We've been
Celebrating
his birthday.
Oh, yeah, that's right. You know, I meant to mention that last week. Shame on me.
My birthday meant last week.
It was last week. I should have mentioned it last week too, by the way. So is a significant age? Did you
65, brother. I'm Medicare age. Yep.
And
65,
I got to tell you, you don't look 65. So
thanks.
you could get away with saying that you're in your late 50s.
Yeah, well, thanks.
I mean that.
I'm a work in progress.
Aren't we all?
Yes, we all are. We should be.
Sometimes people think that doctors are not prone to anything medical, right? They can get ahead of the curve. They can get ahead of everything.
Yeah, well, stuff happens. I'm about to say a bad word, but yes, stuff happens. You never know what Mother Nature has in store for you. It's just good to have help out there when it happens. Yeah.
But there are preventative measures that you of all people know this better than anybody.
Sure. That
people can take. Now, listen. I mean, I don't want to sound morbid, but we're all going to age. We're all going to pass. But we can prolong our life and have a healthy, formidable life. You know, energetic life, full of happiness in our life. So I think it's more or less making ourselves aware of our own bodies. And this is where the average person who is not so medically inclined and doesn't know the medical jargon could really benefit from this show. And actually, not just this show, but meeting with you. We all have these issues. And the older you get, the more of them you're going to have. Yeah. So all the more reason to talk to a doc who specializes in this. Last week, if I remember correctly, we were talking about menopause and, oh my goodness, we were talking in some of the symptoms and how do we know and when does it start and, oh my goodness, how do we treat it and what are all these different things that we can do, whether you're the person going through menopause or you're living with the person going through menopause. You had mentioned a couple of words. Well, I'll take them one at a time. You had mentioned estrogen. And you had mentioned progesterone. Let's take these one at a time. I'll let you pick the order because you would know which one would lead to the second. Where do you want to start? Do you want to start with estrogen or progesterone?
We should probably start with estrogen.
Okay, let's start with estrogen.
Because we're talking about menopause, and basically menopause is estrogen withdrawal. Simple as that. Estrogen is a potentiator of virtually every woman-like thing that happens in a woman's life. It's responsible for breast development. It's responsible for the thing that happens to women's hips when they get older. It's responsible for them becoming fertile when they go through what is called menarche, which is when you have your first period. That's menarche. Estrogen is responsible for a woman looking, acting, feeling, and living like a woman. And it's when we talk about menopause, basically what we're talking about is the moment, it's not really a moment, but of the moment in your life when your ovaries stop making estrogen for the most part. And most of the symptoms that come from menopause, most of the sequelae of menopause, the long-term effects of it come from estrogen withdrawal. So it's fairly simple, It is responsible for maintaining bone mineral density. It's responsible for the lack of it is responsible for the fact that a woman's breasts don't quite do what she wants them to do as she gets older. It's responsible for maintaining the health of a woman's genitals in terms of the vagina becomes atrophic after estrogen withdrawal, which sometimes make intercourse painful. It's responsible to a large degree for a woman's libido. It is very much a supporter of cognitive function. A lot of older people talk about brain fog, and this goes to men who've gone through andropause as well, which is basically testosterone withdrawal. Doc, I'm a lawyer and I got to get all my work done in the morning because by 1 o'clock in the afternoon, my brain is useless, I love my husband, but I just can't. I'm just not interested in sex. And when we do have sex, I don't enjoy it because it's painful. I'm having difficulty sleeping. I'm tired all the time, and yet I can't sleep. It's just it goes on and on.
Is she able to still reach an orgasm?
Good question. It's part and parcel. It's very very much hormonally determined. When a woman goes through menopause, she gets to a certain degree atrophy of the clitoris as well. So it's a little bit harder to have an orgasm. You have to have a partner who wants you to have fun too. It's part of it.
Sure. Yeah. That's just it's tough. But the good news is that it doesn't last forever.
Well, if you don't do something about it, menopause lasts until you die.
Well, no, but with your treatment.
Oh, sure.
Yeah.
It doesn't have to last forever.
Exactly. Yeah. Let's talk a little bit now about progesterone.
Progesterone is part of the balancing act with estrogen. Progesterone is a very calming hormone. If you take much of the myths about estrogen and breast cancer, let's say, women harbor a lot of confirmation bias about estrogen treatment because they've been told it causes breast cancer. Part of the balancing act is the protective aspect of progesterone when it comes to breast tissue. Estrogen is very stimulatory to the breast, but to a very large degree, balancing that with the appropriate levels of progesterone ameliorates that effect. Women who have breastosis, which means sagging breasts from estrogen withdrawal, when you give them estrogen, it brings their breasts back. It makes them palpable again. I really like that effect. But in terms of the risk for cancer and so on and so forth, first of all, using bioidentical estrogen and bioidentical progesterone is part of that balancing act to maintain the health of the breasts. Progesterone is a very calming hormone. We typically tell women to take it before they go to bed because it cures the sleep issues that come from menopause. Literally just cures it. If you put a woman on adequate progesterone at nighttime before she goes to bed, she'll sleep like a baby again. So it's all part of that balancing act. Every cell in a woman's body has progesterone receptors, so it's important to maintain those levels as well as they get older.
What about why do women even need testosterone? Because you associate, at least I do. I associate testosterone with men, like estrogen, with women. But apparently, and I've heard you say this in previous shows, that women need testosterone.
Yeah, they don't need as much as men do, but
Right.
Testosterone drives libido to a very large degree. Libido is desire for sex. If there's some people out there looking it up on Google, it helps maintain muscle mass. It's very important for maintaining bone mineral density. We talk about a balancing act. Estrogen and testosterone are very responsible for maintaining bone mineral density as we get older. So to a large degree from sexual function, testosterone is very important to maintain libido. And if a woman likes to go to the gym and likes to maintain a certain level of muscle mass, they need to have testosterone because it's very helpful in that regard as well. And you talked about orgasm before. I had a woman come to me once. There's a lot of hormone mills out there, a lot of places where you can get hormones that don't really do it medically supervised. And she went to a place and she had pellets placed, and they put pellets, testosterone. We can talk about that down the road, but they put testosterone pellets in her, and she came to me because, number one, she was so horny all the time that her husband was like holding her at bay. And number two, she thought she was growing a penis because she had so much circulating testosterone, because it's very clitoral, maintaining the body. The clitoral body is extremely dependent on maintaining a decent level of testosterone.
Where do these hormones even come from?
Estrogen comes from the ovaries. Progesterone comes from what's called the corpus luteum, which is the remnant of the scar that occurs after ovulation. Mm-hmm. And in women, testosterone comes from the adrenal glands.
Oh.
Yeah.
Oh, really?
So you can see a postmenopausal woman will have, a lot of times will have a reasonable testosterone levels because their adrenals are still working.
Oh, geez.
Yeah.
I thought I heard or read, or maybe I heard a conversation, or maybe it's a combination of the two, that estrogen can cause breast cancer. Have you ever heard of this? Or have you ever heard of it?
I hear it every day.
Oh, okay, so I was going to say, I think last week we talked about myth and myth busting. Well, here's an example right here. All right.
A lot of this comes from boy, you can talk about this forever. There was a study back in the early 2000s called the Women's Health Initiative, which was financed by the federal government. It was done by several tertiary care centers across the country. I think 160,000 women were enrolled in this study, and it was to study hormone replacement in postmenopausal women. First of all, there's a lot of mistakes with this study. Mistake number one is that they use Premarin and Provera. Premarin is what's called a conjugated equine estrogen. It's literally made from the urine of pregnant horses, pregnant mares, I guess. Conjugated equine estrogen, and only a very small component of that is bioidentical estradiol, which is the estrogen that a woman's body makes. Most of those estrogens are horse estrogens. A lot of these women, we talked about this last week, this occurred in the year 2000. They took women they were all postmenopausal. None of them had been treated with hormones before. Many of them were 10 to 20 years past menopause. And many of them had hysterectomies. And so back then, the myth was that if you don't have a uterus, you don't need progesterone. So many of these women were placed on Premarin, a horse estrogen, without progesterone. We talked about this balancing act. So you have women who are taking estrogen or totally in what's called estrogen dominant state. Many of these women were 10 to 20 years post-menopause, so they had plaque, okay? Plaque on their coronaries, plaque on their peripheral blood vessels. There is a molecule that is a metabolite of Premarin that basically breaks up plaque. And these women were having strokes, and they were having cardiovascular events, strokes, heart attacks, many of them because being in estrogen dominance like that were their breasts were very stimulated by this estrogen, and rates of breast cancer in these women went up. And what happened was the media stole the data, somehow got a hold of the data from the study long before it had been looked at by the doctors who were doing it. Mm-hmm. And I can still remember the New York Times, the title of the article, hormone replacement causes breast cancer and stroke. And that was the end of it. That was basically the whole myth of this, the whole confirmation bias of this about hormone replacement came from this study, which is just a terrible, terrible study.
It's misleading.
Totally misleading. And since then, a lot of the data from the Women's Health Initiative has been crunched appropriately, and a lot of good things have come out of it. But those initial headlines are what people have in their heads forever. That's what a confirmation bias is. A confirmation bias is the first thing that you hear about something is the thing that you retain in your mind forever. And there's a lot of things in medicine are dictated by confirmation bias. I had one woman come in who was a patient in the practice, and by the way, is very happy with what she's getting. She left her personal physician because he said, "What are you going to that quack for? He's only going to give you breast cancer." And this is a doctor. This is a doctor who treats patients in our community. You hear that kind of stuff all the time. So that's the kind of myth busting that we do. And basically, the science has been done. The science has been done. Much of this in terms of the cardioprotective aspects of hormone replacement is in the cardiology literature. Much of this is in the endocrinology literature. In terms of testosterone, much of it is in the literature that urology literature. So the science has been done. The bioidentical aspect of this and the balancing aspect of this is extremely important, but when done right, it improves quality of life immeasurably, and enhances and maintains health into old age. I don't think anybody's ever proved that it helps you live longer. It just helps you live better.
Better, yeah. No, I get that.
Better.
Going back to myth busting,
Mm-hmm.
if I remember, it was a week ago. I'm trying to remember. There was a lot of other things that we wanted to myth bust as well, and that we can only get to so many of them, this morning. But anything else that really pertains to menopause or estrogen or testosterone, for that matter, since we're talking about all of it?
One of the things that bothers me a lot is this concept that you can treat osteopenia and osteoporosis without hormone replacement. Really, the only appropriate treatment for progressive osteoporosis and osteopenia is hormone replacement. We see this in our practice all the time. Women who come in osteopenic on their way to true osteoporosis, we DEXA scan them, we get their baseline. We get them on a well-balanced hormone replacement program. They start exercising. We can talk about OsteoStrong at some point. They start exercising because they feel better. All of a sudden, they feel like they have energy to do things like exercise and that sort of thing. We talk to them about diet. We're not really a weight loss center, but obviously diet is always part of the picture. And then it takes a while, 2 or 3 years later, because we follow them on the DEXA, we actually see their osteopenia plateau, and then we see those numbers come up. It happened to Francesca. She was fairly osteopenic, and her numbers are improving steadily now. One of those that taking a pill that makes you sick, Boniva and those other pills, they do improve the DEXA scan. Okay, I'm not sure whether it's ever been proven that it decreases fracture rates. But the way to maintain bone mineral density is to maintain hormonal health. On top of everything else.
And what?
And weights.
Oh, and weight?
Yeah,
weights.
she's talking about using some kind of weight-bearing exercise.
Oh, using weights. Okay.
Yeah, weight-bearing exercise. But the problem is you take a 70-year-old woman who comes to you for hormone replacement and she's severely osteopenic. It's hard to get them to a gym to do weight-bearing exercise because many of them don't have the range of motion that it takes to do it. Okay, their joints are a little bit cold, that kind of thing. There's actually a I'm about to push a particular OsteoStrong franchise. It's called OsteoStrong. It's actually sweeping the nation. And basically what it is, it's a series of machines that even an older woman can use because it uses isometric axial loading of the bones. So in other words, they're sitting in a chair and they're pushing on something rather than doing this with weights, okay? And it's clearly been shown that women who maintain, and it's a once-a-week thing, it takes 15 minutes. It's been clearly shown that women who stick with it, the OsteoStrong aspect of it, can their bone mineral density plateaus and eventually will start coming up also.
Here's another myth, or maybe it's not. Please either confirm or denounce. Speaking of menopause, that a woman should not, if she hasn't hit menopause yet, but she's in her early 40s, maybe 40 through 42, 43, she should not get pregnant because it could compromise the health of the baby.
I'm not a gynecologist. I'm not an obstetrician, definitely. There's a lot of healthy women out there who are having very successfully getting pregnant.
Into their mid-40s.
Yeah, into their mid-40s. You know, I mean, that's something that you should very definitely talk to a fertility specialist about before you. Okay. There's lots of ways of testing during the first and second trimester to know whether or not you're about to deliver a healthy infant.
Gotcha. Folks, you are listening to HyperFit Radio with Dr. Charles Guglin, always joined by his lovely wife, Francesca Guglin. Look at her. Oh, beautiful. Beautiful. I'm Gary
and
Byron.
She's 84.
I know she's. You're so.
Yeah,
really.
Dude,
it's at its
works.
finest
Yes,
here.
yeah.
Wow, man.
Yeah,
give me some of that, you know. Oh, man. So what are some of the risks of hormone replacement therapy? There's always a risk with everything they tell you.
An unbalanced, not well-balanced program, there's some risks. We talked about, breast stimulation of being in estrogen dominance, those kinds of things. The risk for breast cancer is really not there. And I say this to women all the time in the practice. 1 out of 9, 1 out of 8 women in this country get breast cancer during their lifetime. So if I've got 100 women in my practice, 12 of them are going to get breast cancer while they're in my practice. And so the big question is, did the estrogen that I gave them, give them breast cancer? And the very clear answer to that is no. A well-balanced program does not put you at increased risk for breast cancer. Now, one of the things we ask women all the time is we want to know what their risk is. We ask them to get very deeply into their family history, that kind of thing. If a woman has a history of breast cancer, I'm not going to take on the job of restoring estrogen in that woman because it becomes a medical legal problem on top of everything else. In terms of the absolute risk of going on a hormone replacement program, if you don't have a genetic risk for breast cancer, the risk is not increased.
Are there different types of breast cancer, by the way?
Yes, there's a lot of different types of breast cancer. Yeah, what we're talking about basically is adenocarcinoma of the breast, which is the breast of the ductal system, is cancer of the ductal system of the breasts. Testosterone, if the pendulum swings too far in testosterone, you can have some acne problems because testosterone stimulates the skin. It kind of brings that glow back to the skin. Progesterone, really mostly if you're getting too much progesterone, you're sleepy. And so that's something that we are kind of adjusting, because if a woman's taking progesterone at night and she's a little foggy in the morning, then we drop the doses because it can make you a little bit foggy.
Is progesterone its own entity? It's its own pill? Or can progesterone be in an ingredient in another pill?
I'm sure that somebody out there is marketing something like that, but it would be stupid.
Like a hybrid of something.
Yeah, it would be stupid to take something like that because...
Some pharmacies that combine them, but it's easier to control what you're on if you give them individually, because then you can balance it so much better.
I just think of people, and I've heard antidepressants. If somebody is on, if you got a woman, I don't know, of 40s, whatever, that fits into this premenopausal or menopausal, and they're on any of these other medications, thyroid medication, antidepressant or anti-anxiety medications, how does that play in to taking testosterone or estrogen?
It's always part of the picture. It's not there. It doesn't. Many women who've been placed on antidepressants were placed on antidepressants in the perimenopausal phase to treat the symptoms, which is I can't even think of a good analogy. You know, it very frequently makes the symptoms of menopause worse to be placed on an antidepressant. If you take somebody, you take a woman and you kind of restore her from a hormonal standpoint, you optimize her systemic levels of hormones, and you get her feeling better, many times they can then come off those antidepressants. But to a large degree, the only thing that optimizing hormones does is improve quality of life, and sometimes can get people on decreased doses of those. But that's kind of a true unrelated thing. You're not hampering a person's ability to be treated by a psychiatrist, let's say, by putting them, by optimizing their hormones.
We're just living in such a medicated state, it seems like. You know, this person is on there's thyroid medication, anti-anxiety, antidepressants, anti-migraine. Migraines are you know, and there's all this different medication. I just wanted to know how estrogen or testosterone or even progesterone, how it all interacts with each other.
Well, I mean, look, you take a 38-year-old woman who is a well-balanced from a hormonal standpoint, optimized from a hormonal standpoint, because she's still very much premenopausal and having normal periods and so on and so forth. Many of their bodies are flooded with estrogen and progesterone, and many of them are on antidepressants. So, like I said, it's kind of a true unrelated. Don't forget that what we're talking about here are not pharmaceuticals, okay? These are isomolecular hormones that their body was already making. So if they were on antidepressants premenopausally and we optimize them postmenopause, it's only going to enhance their quality of life. It's not something that's going to make things worse.
But can't I just, or anybody just go to their physician and just have their insurance pay for it? Go to their doctor, you know.
No, insurance doesn't pay for this stuff, and most doctors aren't willing to tackle it because it takes a lot of work. It takes a lot of attention to detail. A patient really needs to have your phone number. I mean, because one of the things in our practice, everybody has my phone number. Everybody has my email address. I do a lot of medicine by email, you know, that kind of thing. Especially nowadays. Yeah. And it's a complicated process that most physicians just don't have the time for. You know, those guys, man, they're working their asses off for very little money, and the insurance just doesn't pay for this stuff. We all need insurance. If you fall off a ladder, you know, if you get hit by a car, you have to have your insurance. But that's basically pays for catastrophic care, and it does a great job of paying for that kind of thing. But quality of life issues, you know, some insurance companies will pay for a gym membership. You know, that's a drop in the bucket. Go ahead.
You just don't want to be on those hormones that the pharmaceutical companies are producing, and your insurance might pay for it because they're not natural. They're not bioidentical. They're the synthetic hormones that are out there that can cause all those side effects from those studies.
Insurance won't pay for you to get testosterone until your testosterone level is below about 200, which is basically no testosterone at all. And then they'll pay for androgel, which is an alcohol-based pharmaceutical testosterone preparation that you got to take a bath in that stuff to get your testosterone levels back to what we call optimized. What it will do is bring your numbers up to over that threshold of normalcy, and that's what they'll pay for. Okay, so what we talk about when we talk about optimizing hormones, we talk about goals. Okay, a patient comes to us with very specific goals. All right, and the hormone replacement part of it is part of helping them reach their goals, their health goals.
Over the last 2 weeks, we've talked a lot about menopause and estrogen, testosterone, progesterone. It's just the symptoms, when it starts, the whole 9 yards. If you would like more information on this, I strongly encourage you to first visit HyperFitMD.com. Start there, because that'll maybe even provoke other questions that you can add to your list. Please contact Dr. Charles Guglin. I'm going to give you his phone number. It's area code 203-890-9777. I'll repeat that, 203-890-9777. You can also email him, especially if it's more of a personal nature, cguglin, C-G-U-G-L-I-N, M-D, at hyperfitmdamc.com. And by the way, if you've got
stupidly long,
if you've got a general question, you can even disguise your name or your town or whatnot. We won't mention your email address. We won't mention your name if you don't want it, or make one up, or your town for that matter. But if, you may be helping others if you would like to email this radio show. That's very easy to do as well, my friends. hyperfitradio@gmail.com. Once again, hyperfitradio@gmail.com. Really quickly, in about 10 seconds, where do you want to go next time? Do you want to go where?
Let's talk about erectile dysfunction.
You want to go there? All right.
Sure.
This might lead to a couple of weeks again.
Yeah. Let's talk about erections.
Hey, all right. For Dr. Charles Guglin, for Francesca Guglin, I'm Gary Byron. Thank you so much for listening to HyperFit Radio Show. Until next Saturday, same time, same station. Have a good one, everybody. So long. Saturday morning to everybody, and welcome.